So quite a comprehensive team. We had 6 dedicated beds on our long-term ventilation unit and shared beds in the high dependency unit for the Evelina. We had, just before the lockdown, 9 inpatients, either waiting to be established or waiting to go home. And at home, we had active more than 200 patients that we looked after, with 45 tracheostomy and the rest on non-invasive ventilation. All the care was done mainly face-to-face, with the exception of the CNS telephone clinics, with an outpatient waiting list for face-to-face only behind about 2-3 months, only inpatient waiting time for initiation 3 cases, and the follow-up pretty much on track. So yes, so we were doing well, we thought. Next slide, please. And then the coronavirus came and hit us hard, as hit everyone else. So why St. Thomas and Evelina became a coronavirus hospital, and especially St. Thomas Adults and ECMO Regional Center, we had to restructure the service. We had, and the balance was between keeping open the service for LTV children and for the network, for the referral, for the ongoing troubleshooting. When our staff was reduced consultant to 60%, fellows got redeployed, and we lost a third. The clinical nurse specialists, obviously some of them were redeployed, and one had to shield and was working from home and single-handedly pretty much helped us with keeping all these children at home safe. Our unit had to close, so our protected unit had to close to redeploy the staff. The outpatient was closed. The HDU was open mainly for acute. PICU had to relocate to level 6 and allow the adult intensive care to use our PICU beds. And this was in line with the restructuring of the critical care beds in London and the network, which we are all aware of. Next slide, please. So as we were watching through the woods and listening to the daily government updates, as you can see, this is a view from our ventilation unit for the Houses of Parliament. Unclear every day and more confusing every day. So we had to be prepared for the battle. So in the acute phase, we had to convert the entire LTV care to virtual. We didn't stop neither follow-up, neither consultation, neither follow-up sleep studies. So we converted basically all our clinics to video using Attend Anywhere platform, which probably most of you are using, and it's very good. And we converted the ventilation studies from the unit to be done at home, some of them cardiorespiratory, some of them oxycapnography. And the sleep team was amazing and helped us to do about 15-20 per week. The inpatient care was reserved for acute urgent patients. We had to send all the validation letters for the shielding for our patients. And what we found that we had to do on an ongoing basis is to update our website. And we done a video for the Well Child team because family was so anxious and they need to be reassured and keep up to date. Next slide, please. So the flight stopped. As you can see, our patient, he's tracheostomy ventilated, didn't fly during coronavirus, but did enjoy to be in the pilot seat. We have to say a big thank you for our executives who spoke with our local hospices, and they accepted and they helped us in the discharge process for the families that weren't ready to go home, but they were ready to be discharged from the hospital. So our pathway for discharge was massively helped by the local hospices. Next slide. I will present only one case from our patients. So we had about 3 or 4 that we couldn't troubleshoot at home and adjust the settings. And I'll present only one case. It's a child with congenital central hypoventilation syndrome that we managed non-invasively, was discharged in December. Had 2 Trilogy portable ventilator, ventilated on a pressure control mode with reasonable pressure, 16/4, rate 30, who was doing well. I saw him in a video clinic in April with one of our clinical nurse specialists, with Lucinda. And the only concern that father had at that point was that she wasn't vaccinated because they didn't go to the GP. And then we organized for just a routine surveillance oxycapnography study. And we noticed that we've done it twice and CO2 was high and variable. And I kept asking, is the child well? And father kept saying, yes, she was well. So I don't know what you would do in a CCHS child, but we decided to admit the child to high dependency to see what's going on and observe overnight. So we admitted the child. Next slide, please. And again, mom reiterated the child was well, but all the patients get screened at admission, and surprise, surprise, the cause of the entire destabilization of the ventilation was the child was coronavirus positive. And asking mother back, was the child well? She did say in the end, yes, the child had diarrhea, but in a 2-year-old, she thought the diarrhea was part of her normal picture. Parents completely asymptomatic. So the message would be if a ventilated child is not well and doesn't cough, doesn't have fever, because children most often don't, just think coronavirus. This is what we found in our CCHS. By the time we admitted her, the sleep study was normal and we didn't have to change anything. Thank you. I will hand over to Tamsin. Sorry, that's my slide as well. So during the lockdown, we continue to provide the clinical care. We had no PICU admission, very few HDU admissions, 3. We initiated 2 patients in HDU and managed to discharge quite a lot. We had the regular network meetings and discuss the equipment issues. And the things that challenge us were the ongoing changes and uncertainty with regards to the advice and how to manage coronavirus overall. So I will hand over to Tamsin to continue.
Next slide, please. Oh, good afternoon. My name's Tamsin Hernandez. I'm one of the long-term ventilation CNSs here at the Evelina. So I'm just going to talk about some of our experiences through the pandemic. So first of all, I'd like to say that our patient cohort on the whole has kept well through the pandemic. I'm sure that shielding at home has had something to do with this. Of the 210 LTV patients on our caseload, to my knowledge, we have had 2 COVID positive cases within our LTV population, of which both had just mild symptoms, reassuringly. As our hospital-based inpatient and outpatient services closed, as Simone has already talked about, we were able to deliver a large proportion of our services at home. And that's something we talked about for quite some time. Before COVID actually was about being able to carry out, for example, the virtual video clinics to support the families in their own home, to reduce travel time to the hospital, as our patients live across the whole of the South East, as you're aware of. And COVID has expedited this, allowing us to be able to move forward with the virtual clinics and home sleep studies. Some of the challenges that we've faced along the way, as I'm sure you all have, is one of the biggest challenges probably is the uncertainty and the changing in advice. And as CNSs, we were there to support our families and to support our colleagues across the community in signposting as needed. We had quite a few issues with regards to some of the equipment as well, with shortages out in the community with regards to parts of circuits for ventilators, for example. So we were able to support our families and reassure them and work with the STPN and the Paediatric Pan London LTV groups to support each other in sourcing alternatives and changing some of our practices quickly to reduce concern out in the community and in hospitals as well. The impact that shielding has had on our families from a mental health perspective, we have also seen, and with less face-to-face therapies and support out in the community through the pandemic, has had a huge impact, and also with domestic violence in the community, as I'm sure you're aware of. The stress on staff of redeployment and coming back to work in an ever-changing situation was also quite challenging for us. And PPE, as advice on that changed, at times could be unsettling, but we never felt without PPE. but also signposting our colleagues out in the community with agencies, for example, to the PP, types of PPE for AGP procedures. Next slide. So, you know, all of us in our team were redeployed in one way or another. And it felt like we were a bit of a jigsaw, and each time part of that jigsaw went away and came back, the service had changed a little bit more. And so the clinical nurse specialists, for example, we were redeployed on a 2-week rolling rota into the acute setting. So being away from the service for 2 weeks and coming back was quite a challenge, as so much changed. Our physios, for example, and consultants were on a 7-day working week. So although we were able to cover 7 days, for example, at the weekends, that meant that there was a physio who was able to do training to discharge patients, but it meant that we didn't always have our own LTV physio with us. Next slide. The team worked at speed to provide guidance and SOPs to support the safe delivery of care, from development of action cards on the guidance for filtered circuits for use in suspected or positive COVID cases for our paediatric LTV patients, to the development of SOPs for the provision of sleep studies to be able to carry those out safely in the home. Next slide. So as Dr. Turkey has already explained, we've been able to carry out a lot of things virtually, from virtual meetings to support discharge planning, to virtual clinics where we've been able to carry out mask fits, for example, in the home for our NIV population, which ordinarily the children would need to come into the hospital for. We've been able to do that quite successfully. To training and supporting, to offer support training to care agencies and also to family members, to support the children out in the community through this. Some of our families decided to drop their care packages through this because of their concerns and worries. And so requests for an additional member of the family to be trained as a constant, we were able to support. We were also able to carry out our home sleep studies, as we've already said, but we were able to not just carry out studies as they are, but we were able to escalate, wean, change settings and modes of ventilation as needed, with daily support from the CNS virtually, and that has been quite successful. Next slide, please. So the battle continues as it is. So we are now coming back to opening up our inpatient services. So our long-term ventilation unit, Snow Leopard, which has 6 beds for LTV patients, is reopened from July. We reopened on a smaller number of beds, but we are now bringing that up to capacity. The biggest thing at the moment is managing parental anxiety, understandably, of coming into hospital and travelling up to London from all over the southeast. So supporting those families in travelling through arranging transport to come in. We swab our patients on admission, and then they have swabs at intervals throughout the duration of their stay, depending on their length of stay. All of our areas are AGP areas, and so full PPE is worn, and that is quite difficult. Well, not difficult, that's the wrong word to use. Can be a challenge when you're trying to communicate with the children and families. We have less space for our outpatient services, so there will be a place for the virtual world to continue, absolutely. We have cut our face-to-face clinics currently. Our respiratory support clinics, we hold 1 every 2 weeks, and we can only see 3 patients per room because of the AGP, and the rooms have to be cleaned and aired and left for an hour in between patients. So that's quite difficult. Next page. Next slide, sorry. So what's next? Well, I guess we don't really know what's next. We have our predictions. What we'd all like to be is smiling still this time next year, like we are here. This is all members of our team. Staff wellbeing has been really helpful and supported us all to manage through the pandemic. But who knows what's next. Thank you.
Thank you very much, Simona and Tamsin.
One more slide, sorry. Yeah. So just to end really, that it's finding a fine balance of managing risks and safety of our patients, and that we just continue on this marathon, although it does feel like we're sprinting at times. Thank you.
Thanks, Tamsin. I think you summed it up beautifully there. It's a marathon, but there are moments where we feel like we really have to put in extra effort and have that sprint halfway through the race. So thank you for sharing those experiences, but mostly for the support that you've provided to your patients during this period. So next up we have Billy Cavalli, who will be presenting the King's College perspective. And as I've said, we do have to say thanks to Damien for helping to put together these slides.
So hi, my name's Billy. I'm one of the respiratory CNSs at King's, and as mentioned, I'm presenting on behalf of Damien today, who's not here. And I'm going to be talking about the use of home monitoring and excellence during COVID. So just a few different examples of ways we adapted during COVID to make our service still run. So the first one I wanted to talk about was our move to home-based sleep studies. Next slide, please. So our initial response was the rapid setup of home O2 CO2 sleep studies, and we were using our existing radiometer TCM5 machines that we already had. Next slide, thanks. So what are we doing? Well, before patients can collect the studies, we were screening them for symptoms. We were then meeting parents outside of the hospital for collection and return. So a lot of running back and forth to the car park for us. But the reason was that we didn't want parents to have to come into the hospital unnecessarily. And then for those patients that we didn't want to bring up to the hospital at all, that may have been shielding or would have had to have come by public transport, we were using a courier service to get the machines to and from their homes. And to support all this, we've then developed a lot of new SOPs. We've had a few obstacles along the way, including reduced staffing and admin because of staff shielding, but we've overcome those as well. Next slide. Yeah, thanks. So where are we now? Well, we've actually had a dramatic reduction in the waiting list for our sleep studies. So we've moved to mostly home studies, and they've increased, and they've almost more than doubled since we started. And then a large proportion of the patients who still had to have their studies as inpatients were patients that we were initiating onto NIV and LTV. Other patients that we had to bring in were sickle cell patients who needed oxygen initiation, and they had to have that as inpatients. But weaning has also been really successful in the community, and it's just meant that we've been able to really increase the number of studies that we've been able to carry out. Next slide, thanks. So we have had some failures in our studies that have come back, so it's not all been success. We've had a couple of cable faults, but that happens anyway, and we just had those replaced by radiometer. The things that we were finding cropping up more regularly were that the TCM5 machine actually wipes the data if the device isn't plugged in all night, or if the probe isn't placed back into the machine before turning the study off at the end. So we were getting a lot of machines coming back with no data on them from the families. So what we did in response to that was we set up initially a robust step-by-step picture guide, so parents could follow the pictures step-by-step as they went through the setup of the studies. But we were still getting studies coming back blank. So we decided to get our sleep technicians to call all of our families overnight. So they call them every night at the setup and offer support all night long. So that's a service that's available from 7 p.m. to 7 in the morning. We still, however, were getting failures. So now we've set up a video. So we recorded a training video. So now there's like a web link and a QR code on our information sheets that we send out to families. So they have those to help them with troubleshooting. And then if they still fail, what we're now trying to do is bring patients in for admissions. But it's we're trying to use it as our last resort. We're not planning to bring patients in at the moment unless necessary. Okay, then next slide. Thank you. So the future, well, we're going to continue to monitor the feedback that we're getting from families and see what their patient experience is like and monitor our failure rates. We're proposing use of Attend Anywhere virtual clinics that we're using for daytime clinics at the moment, but what we'd like to do is set them up in for the nighttime so parents can actually have the setup talk through via video link, which should be helpful for them. Going forwards, we anticipate that we're going to have better treatment times for our NIV and LTV patients, because previously they were having long waits to be able to get them into our HDU area, which is where they would have to come into the hospital. And now we're far more able to do their studies at home. It means that they won't have these long waits. We also plan to have service meetings so we can make sure this service is sustainable going forwards. Thanks. Next slide. So now I want to talk to you just about a case study, about a scenario where remote monitoring has really worked for us. Next slide. Thanks. So it's a case study using AirView with a ResMed device. So what happened was we had a child that had a sleep study, and we planned to admit them to increase their pressures, because on the study it showed that there was a 3% dip rate of over 10 per hour. And their mean CO2 was 6.8. So we thought we were going to have to admit them to increase their pressures and study them overnight. Next slide, please. But before we did that, what we did was we looked at the remote monitoring that we had on their vent, and we could see that the leak was really quite bad with their mask. So initially we called the patient and talked them through mask fitting, and it became apparent actually that their mask didn't really work for them. So what we did was we gave them a new mask. Next slide, thanks. And as you can see from the graph, that their leak was dramatically improved, and we re-studied them at home, and their CO2s were greatly improved and their dip rate was improved. So that's an example of where we managed to sort all of their problems out at home without needing an admission to hospital. Next slide, thanks. And then, so the final thing that I wanted to talk about was just episodes of outstanding care. These are actually, the outstanding care is actually the community that has been providing this care for us and made our service possible during COVID. Next slide. So the first one was, we had a child who had learned, a toddler that had learned to pull at their tracheostomy, and they were really pulling at their tube and their circuit. We recognised that there was a real risk of this child getting decannulated. But as the family was shielding, we really didn't want to bring them into hospital. So we contacted the care team, who were quite experienced actually in using the twill ties, and they agreed to train the parents in the community. And otherwise, we would have normally just brought them into hospital, so it would have required them to come in. So it was really good, because we prevented them having to come in while they were shielding, and we maintained safety for that patient. So the community were fantastic, they provided a fantastic service to us in that instance. Next slide, please. So the second one was a patient that was experiencing a high volume of alarms coming through their vent. And it seemed to us that it was just a case of their leak was increasing as they were growing, and really they just needed their alarm parameters amending. And again, the community, the care agency volunteered to go out to the home, and with our instruction, change the parameters of the alarm settings. So they did that for us, and they took photos of each of the changes that they made, and then they emailed us those settings so we could see exactly what they'd done. And again, it prevented the child coming into the hospital, and it stopped all those nuisance alarms that can, create alarm apathy, and so increase patient safety again. Next slide, please. Yeah, and then the last case was just a patient that we actually managed to wean from BiPAP to CPAP in the community. So ordinarily, this isn't something we would consider doing, but this child had actually had CPAP before, and just as COVID was starting, they'd been unwell and they'd been put back on BiPAP. And then ordinarily we would have brought them in to sleep study them and return them to CPAP again, but we hadn't been able to do this due to COVID, and it had been a couple of months and they were still on BiPAP, and we really wanted to switch them back. So what we did was we asked the community team to add an additional setting onto their ventilator. So they still had the BiPAP settings there, and then we put an additional CPAP setting onto the vent. And again, they emailed us the screenshots of the changes they've made. So overnight, they provided nurse cover. So normally the patient had carers, but the community team offered to provide nurse cover overnight, just for that additional support and assessment of the child, just in case something was not quite right. So we gave them strict parameters. Oh, sorry, could you go back to the other? Yeah, thanks. So we provided strict parameters as to if the child's oxygen levels dipped or their CO2s were going up, they must switch them back to BiPAP again. And as it was, we carried out the sleep study and the patient did really well. So we managed to keep them on CPAP, and they've continued on that since. So that was very successful. Next slide, thanks. Yeah, so I just wanted to say a big thank you to our fantastic community teams and care teams who have really made our service work during the times of COVID.
Thank you very much. I think those are really excellent examples of how we've changed our practice over the time of COVID, but actually great collaboration between the community teams and the hospital teams. I think the other example is clever use of technology. So normally we're trying to avoid people using their phones when they're at work, but actually being able to take screenshots of equipment and feed those back to the teams in hospital has been particularly helpful. So thank you very much for that. So moving on to our final set of speakers, and I must say it feels like this time has rushed by extremely quickly. So thank you both to the Evelina and the King's team for interesting perspectives on your experience during COVID. So the next speaker that I would like to introduce is Tara Parker. Tara is Director of Programs at WellChild, and we have been extremely grateful as both the North and the South Thames teams for the support provided to families and the interactions that we've had with WellChild, giving us insights and perceptions into the challenges experienced by families during this time. In the question section afterwards, Callum Campbell, who's the Family Information Officer for WellChild, will also be available to answer any questions that have arisen. But before I monopolise any more of your time, over to Tara Parker.
Hi, as Marilyn kindly said, I'm Tara Parker from WellChild. We're going to talk a little bit about Left in Lockdown, which is parents and carers' experiences of lockdown. And this was a report compiled by the Disabled Children's Partnership, which we are one of the lead charities in, but there is actually a total of 70 plus charities in now. We had a response from 4,074 parents, mainly these are parents with children with complex long-term disabilities and complex health needs. And you can see, you don't need me to read them to you, that there is a breakdown there of the different types of disability they have, and that probably sort of fits with what you would expect really in terms of needing things like LTV is going to be fairly low down there because there are a fairly small amount of children with those sort of conditions. And we ran that in May, so people who are a little bit into the COVID pandemic by then. We can move on. So the impact on parents and carers, we started to see that parents were really providing an awful lot more care. We run something called the WellChild Family Tree, which is a support group when we can see parents chatting to each other and commenting. And the survey really backed that up with 72% of parents providing a lot more care than before lockdown. And 54% of parents saying that their general health has got a lot worse. And 79% saying their emotional and mental health is worse. So parents really were struggling. And I think when you see figures like that, 76% of all parents reported that all support had stopped during lockdown. So the amount of people that had no respite, no carers coming into the house, and there were lots of different reasons for that. And we'll cover those in the next couple of slides. Do you want to move on? So the impact on the children themselves, 86% felt that the lockdown was having a negative impact on their disabled children's learning and communication, and 87% said it was having an impact on their behaviour. People also talked a lot about siblings. 2/3 of siblings, non-disabled siblings, were providing a lot more care. They were taking up the slack, and they really did feel that their mental and emotional health and well-being was certainly an awful lot worse, and that's something that we've certainly seen reflected across mental health services in England, certainly. So interesting to also see that 45% of parents felt their disabled child's health was actually worse, much higher again, 71% for emotional health and well-being, but certainly around about half the people did feel that the general health of their child had actually been impacted by COVID, not by COVID, but by the situation. We can move on. There's just a couple of the sort of really standout quotes that people said. The disability social work team have not checked in or even paid lip service to see how we are coping or how they might be able to help remotely or otherwise. And I think there's a couple of others on the next couple of slides. So we now have no respite and no break from 24/7 care needs, plus we're expected to homeschool 2 children, including modifying homeschooling work for the visually impaired child. We now have no therapy intervention at all. This has been detrimental to my SEN child's progress and health. We are all completely exhausted, both mentally and physically. And I think that probably sums it up. It's like living in a pressure cooker. It's constantly and endlessly exhausting. So I think some of the concerns that we would have about parents' resilience, particularly going into this winter when they tend to need to be a little bit more shielded and a little more guarded, and their children tend to be quite vulnerable. I think some of our concerns will be about the levels of resilience that they've got and the levels of resilience they've got if schooling and other things start to lock down again. Interestingly, what do you think families think would help? I mean, other than things like increases in benefits and money, which is probably a fairly general complaint, 84% thought that unpaid carers getting COVID testing, like other non-essential workers, would really help. Interestingly, that was one of the calls that we made, and that has now become the case. And so therefore, I'd like to say to you that that's happening, and that if you're an unpaid carer, that you can get tests. Unfortunately, as you will all have seen, that there's been an enormous rise again in COVID cases and outbreaks and issues over the last couple of weeks. And in fact, paid carers are really struggling to get tested, let alone unpaid carers. And we've had people contacting us saying, our carer lives with somebody who's become unwell, they can't get a test, the carer can't get a test. And I think that's become quite worrying. I think at the height of the pandemic, interestingly, when people were in lockdown, our cases were dropping, getting a test wasn't that problematic. And one of the things that the government have promised to Well Child and Disabled Children's Partnership is that people will be able to, unpaid carers and paid carers will be able to get access to testing. And certainly that hasn't been the case. And we ourselves, I have unfortunately had my own experience of that today with one of our carers not being able to get a test despite living with somebody who has just come down with COVID in a student house, and she should be working for us this weekend and she can't get a test, not at all, not for the next 2 weeks. So I think there are some real worries around whether that that service has been put into place for families and for carers. Otherwise we'll very quickly see a breakdown of care again. Okay, moving on. Lovely. So DCP and Well Child made a call to the government, and we have met with several government ministers over this. And what we were really asking for was a cross-departmental government plan of support for families of disabled children, and additional guidance on government plans for those required to shield for longer periods. So shielding has been something else that parents have really struggled with. We really worry about this winter and a risk of a second wave, and people's rights and equalities as lockdown eases for the majority of people. A lot of these children are still suffering inequalities, really. We still have hundreds of children not back at school due to the AGP guidelines not having been comprehensively agreed and schools being unable to agree. So we've still got lots of children. It's a big complaint this week and last week, particularly, that children are not being allowed back into schools. We've got the issue with testing already. People are saying they can't get testing. We're looking at the reopening or expansion of home, community, low-level mental health CAMHS and short break support for disabled children and their families. Despite mental health services trying to stand back up, there is still an awful lot of those services that are affected, particularly in London actually. Ensure that NHS staff now are redeployed into their substantive posts. So one of the other big problems that people have faced is that their therapists and their speech and language team and their physios and all of those sort of people were the people that were redeployed in order to cover things like COVID testing and work in the temporary hospitals, etc. And we're still seeing a surprising amount of those services, again, not stood back up. And then there's just some info there about the funding gap, 1.5 billion across health and social care to exist. That's an existing gap we knew about, but when we get access to the government, it's worth throwing that in. So that's what we've called for. Moving forward. So what Wellchild did directly, COVID-19 direct response service, when we start hearing all these things in April, when parents start contacting us saying these are all of our issues, we have to think about which of those issues we could try and help with. And if you move on, we can have a look. So why? So significant impact of a UK-wide lockdown on families with complex needs, children and young people became clear after just 4 weeks. With schools closed, therapy stops, care was withdrawn, new rules on ADPs and PPE came into force. Shielding guidance was issued and reissued regularly. PPE supplies were impossible to source, affecting care. Families were frightened to leave their homes, but were unable to access food and medication deliveries, and family support disappeared almost overnight. There was a real dawning reality for our families that they felt forgotten. So that was why. And now moving forward. So when and how. So 21st of April, we contacted suppliers and funders and asked for donations of PPE or funds to buy it. And we were really fortunate because it was right at the beginning of COVID where companies really felt that they wanted to donate. I have to say, I'm sure that won't be as easy a second time around. So we managed to focus on 3 key areas: provision of PPE, assistance with food deliveries and delivery of prescriptions. And we aim to provide emergency supply along with long-term solutions. So we worked closely with NHS England to try and work out why these families couldn't get the things that they needed. So 1,336 people have requested support, and we've sent out, as you can see, over 1,000 orders of PPE, which is 253,000 plus individual items of PPE. And we've sourced over 300,000. And you can see on the right there sort of some of the numbers. So a lot of the things we provided were things like scrubs for carers to wear. And a lot of this was around the work with the network about trying to persuade families where care was on offer not to turn that care down. That seemed very tempting to a lot of families, I think, at the beginning. But I think one of the things that we really recognised was that people would burn out and their resilience would wane very quickly. But actually trying to persuade people in those really frightening first few weeks that their child will be safe. So you can see some of the levels of different kit that we've sent out. So little did I know I would ever become an expert in warehouse resourcing. And on to the next slide. We also provided a wealth of online information for families, which we wrote again in conjunction with the networks across the country that we work with, including the Royal College of Paediatrics and Child Health, etc. Just on how to access food. We tried to get people, we managed successfully to get lots of people onto supermarket lists, and where we couldn't, just to get local volunteer services and the National Supply Disruption Service working to help them getting the things that they needed, and all of that's still available on our website. Moving on. And ventilator supply shortage. Since we were talking to the LTV network, we thought that we should probably talk about the fact that this became quite a public story, and I had a really busy weekend of doing lots of news and television interviews regarding this situation. So if we move on to the next slide. We started to get an awful lot of contact from our nurses and families saying that they were anxious over the fact that they were being asked to change their usual protocol, usually in response to a consumable shortage, bacterial filters, tubes, circuits. You can imagine there was quite a lot of anxiety around that, really, and around the safety. And although I believe, and you're probably in a better place yourselves to know this, that there haven't been any massive adverse events from it. It is extremely worrying from parents, and parents were then sent advice from the consumables companies saying that they shouldn't be changing their plans. So there was some conflicting advice there. But I think one of the things that we were really concerned about is why those supplies were not ring fenced. So this is not long-term ventilated children are not an unknown cohort. And so one of our calls to the NHS and to the Department of Health really is about how they're going to ensure that those supplies are not going to be used should we hit a second wave, and how they're going to be secured through the winter months. As we move to the next slide. So we certainly found it was a postcode lottery. Not all areas experienced these shortages. We were a little concerned about NHS staff not being allowed to comment. So they were, when we asked for direct quotes, most comms teams shut that down. And I think there's something a little bit worrying about that moving forward, about honesty and open and transparent practice. We also were a little bit surprised that the NHS's response was that NHS trusts experienced shortages just didn't know who to contact. And I suppose there's a little bit of a worry about why they didn't know about the national supply disruption chain. And if they'd have known about that, then they would have been able to access that, and that would have flagged at the right level that there were those shortages. So we have received response now from Edward Agar, the MP, and the Minister for Health, and we have also had contact with the NHS England team, who are mainly a team that Deloitte, seconded staff from Deloitte, that are helping with supply chain issues, and we have been reassured that supply chains have been restored. They felt that it was a measured risk, and that had they known about the shortages experienced, they would have helped and provided necessary supplies earlier. So I think our message back to them was a little bit about communication, because if the staff in the hospitals didn't know how to contact them, then you can see how the whole situation ended up as it did, with parents literally on their last piece of equipment on the day they got deliveries, etc. Moving on. And that's it. You can see Kat from Kings. So thank you very much.
So Tara, thank you very much. As always, it's so important to be able to hear the perspective of families, and we absolutely appreciate the link that Well Child has provided for us, so that we are able to hear those voices directly. So I would also like to thank Teresa Davey, who's been controlling the slides behind the scenes, and Miriam Khabib, who helped to set this workshop up. I was wondering if I would have to lead off the questions, but I can see that Francois Abel has his hand up. So Francois, would you like to ask your question? And is it directed to anyone in particular?
Thank you, Marilyn. No, it's actually more a comment than a question. Responding to what was said in the first presentation, or second actually presentation from Tamsin, where she said there was a lot of one of the reasons that may explain the thing is the fact that a lot of patients were shielding, and then therefore there was less risk of infection. But I think that's a common thing that we hear that needs to be put into context, because if you look at countries like Sweden, where ventilated children are still going to school and didn't go into lockdown, there hasn't been a particular increase in infection in those groups either. So I think the idea that the shielding is the reason why there's not been a lot of infections in our ventilated population is not necessarily absolutely right. I think there are evidence as well that when there hasn't been shielding and lockdowns, it hasn't been significantly increased. I think it's an important point with regards to the return to school of our ventilated population, because I think we need to be careful about over precaution and denying, as Tara mentioned, the right to go to school for this population, because this is the most difficult population to convince schools to that they have the right to education and to go back to school. And that's a big concern of mine. In we've had that feedback, and I'm sure you've all had the same thing about how difficult lockdown has been for the LTV and NIV population, the psychological impact and the difficulties that they feel about not going to school, balanced in the other hand with the risks that they were worried about coronavirus. But from that point of view, the evidence is not there for all the published literature. And there's published literature from Sweden. There's a big study from Düsseldorf that's looked at the rate of carriage in the pediatric population, and all of that are have started to feed the narrative on the fact that we should allow these people and these ventilated children to go back to school. This has been discussed actually at a higher level and with NHS England, but everything goes very slow from that point of view. There's been a lot of discussions around that. Like many things in education, the document is triple locked, and there's a desire not to rattle the unions, which is part of the problem as well. but there's discussions that are continually going on with Public Health England to try to get the current guidance amended, but the process is very slow and frustrating. But I think the idea behind this, I don't want to take too much of the time, but that well children on ventilation units across the UK have been managed using droplet PPEs without evidence of cross-infection. And so the guidance would recommend that asymptomatic children on ventilation and with tracheostomies can be cared for safely using droplet PPEs. And finally, there are some schools who already used specific systems. They've bought like little tents that you can buy on Amazon to care for patients on ventilation and stuff like that. And they've already, gone ahead to try to accommodate these patients. And I think that obviously there's going to be individual risk assessments for every school, but I think they could take example of these schools who've gone ahead and tried little systems to try to accommodate these patients.
Thank you, Francois. I think there are lots of good points there, and I think it does remind us that we really do have to advocate strongly for this group of patients, that they don't feel like they're still left in some form of lockdown. Callum, I'm aware that you haven't had an opportunity to speak. Is there anything you particularly wanted to add at this stage?
Not particularly. I mean, just to kind of echo what Francois was saying, Welsh Health are now campaigning because we've had a lot of reports of children who require AGP being barred entry from school, essentially, because the school, for some reason, cannot follow the government guidance on the enhanced PPE or the need for a separate room for where PPE needs to take place, for where AGP needs to take place. So yeah, I think it's just really important that we keep on kind of campaigning to get these children safely back to school wherever possible. Thank you very much, Callum.
So I suppose one question that I have, because I can't see any other hands up at the moment, is both to the Evelina team, so to Tamsin and Simona, and then to Billy and Cara Bosley, who I see has joined us from King's as well. When we went into COVID the first time round, none of us could have expected the changes that we saw. But knowing what you know now, are there things that you would do differently? So if, as we face the second outbreak, what would you recommend? And I see Francois kindly shared his picture of that tent that's available on Amazon for everyone. But yeah, for the teams who've been through this once, what would you do differently facing it a second time round?
I think it just showed that the virtual LTV care actually works, and not to be afraid of using it. And yes, face-to-face is important, but actually there is so much you can do virtually that we will just keep the good points and continue. And I think Francois made a very good point. I think what we learned is that LTV children don't get sick. Even the CCHS I showed, yes, the CO2 was all over the place for about 2-3 weeks, but then got better without us doing anything. So I suspect the emotional part, I think, would be the most important. Reassure the families that, things will be good. Reassure our staff, our team, that there is no need to panic and get stressed over your head. Yes, coronavirus is a pandemic and it's a public health issue. But I suspect going to the second wave, which will come, just keep calm.
I think that's right. And I think maybe more support from psychology, although everything's very difficult to implement very quickly. I think it was quite astonishing how quickly the NHS did work during COVID, how quickly the NHS reacted when we've all had, several decades of finding change difficult. So I think that's one of the good things. I think the joint meetings were actually really helpful, sort of collaborating and talking about issues such as being described in the Well Child talk about, you know, supply issues and then trying to just come to a consensus together shows how we are all working for the same aim to help the children and their families. I think in retrospect, for me, from our service, I think we did well with the SEEP service, but I think maybe we could have done more video consultations a bit sooner. We're doing that now, but possibly we were doing too much on the phone. But it was also, we didn't describe, but a lot of our CNSs were also pulled away, not so much the medical staff, but maybe we could have done a bit better with that. But as you say, it's sort of hindsight, and I absolutely agree with you, Francois. I think the children should come first, and they should be prioritised for their education. So important. So that would be my take on it. Don't know about Billy. Yeah.
I think as well, just to reiterate that, in terms of the school, and it's an interesting one because people talk a lot about education, and then people get very confused about children with long, complex health needs and disabilities and think, well, is education that important? Fundamentally, school is a really different thing for them. It is about therapy. It is about all of the things that you need, and I think you cannot underestimate how the whole system-wide shutting down of that.
Yeah.
Even when you're, and I sit in both camps, as most of you know, I have a daughter with complex needs who's 21, and she was in the same position. We're facing a hip replacement probably a year sooner than we would because we've had 6 months of no physiotherapy, nothing. It just stopped. She then did her COVID lockdown on morphine patches, and before that we were doing really very well. And actually, we didn't have hydrotherapy, which is still not open. And I think actually I'm just one of thousands of parents, and my daughter is a bit older now, but actually it's been huge, that impact. And you look at your teams, and we ask parents to submit their teams. You often have between 40 and 60 people who help you raise these children. It's not just you on your own. And actually you take almost all of that away. And when they're in school, an awful lot of it's accessed via school. And I think there was nowhere near enough importance placed on that. And I think the big disappointment for us is that having gone back, I'm not suggesting for 1 minute that it's not important. Other children are in school, of course it is, but actually for a different set of reasons it's important. These children are back at school, but because of their medical needs, they're almost the last to be allowed in. They're the first to be shoved out. And actually, I would argue the point
and
that
how is that fair? That can't be fair. That's not fair. I totally agree.
They take too much personal care. They're needing to be touched. The people are needing to be near them. But as you rightly say, they are young people and children, so their chances of carrying it, and also their lives outside of school and college, are often much more limited. So they're not in pubs and bars and clubs and restaurants. They are actually probably just doing those two things. And I think it's just I just think you're right. It's an important, and I think the other real lesson is to explain to people, you're quite right, vintage children, vintage young people are still, even when they're diagnosed with COVID, are just bouncing straight back out of it. I know there were 3 at our daughter's college. They were the most unwell, vintage children, all completely bounced back out of it very easily. So I think that reassurance to give parents, but I think it's then really disappointing when the system doesn't react back and they say, well, actually, let's keep the vulnerable at home. Everybody push for schooling because it means so much more to children with disabilities in a lot of ways. It's really about health.
So I'm afraid we're going to have to end there, but those are really powerful images and important messages, Tara. So thank you very much for reminding us how much more important and how much more value there is around supporting children with complex needs at this time. I think I'm struck with that image of parents who are both mentally and physically tired. So I know there's been so much emphasis on healthcare workers and how we've kept going during COVID, but I suppose just a reminder to be kind, caring and supportive to those families we're looking after as well. So thank you very much, all of you, for sharing your experience. And we look forward to seeing you, remember, next week, same time, same place, Wednesday and Thursday, 4 o'clock. Please do join us. Thank you everyone for your contributions. Goodbye.